my presentation will be about the treatment of diabetes in elder patients. And this is a very important issue because the world population is aging more quickly than ever before. The average life expectancy actually in the world is about 72 years. And the problem is that for all the governments all over the world, then they will have an increasing demands for treatment for population and especially in the healthcare system. Between 2015 and 2050, the proportion of the world population over 60 years old nearly will double from 12%, about 900 million people, to 22%, more than 2 million. And by the end of 2020, the number of people aged more than 60 years old has outnumbered the number of children younger than 5 years old. And more than 80% of older people will be living in low or middle income countries by the year 2050. This is true not only for the general population, but especially for people with diabetes that are living longer and longer and having almost a normal life expectancy. And today we have champions living with diabetes for more than 80 years, like it is the case of Clifford Whitaker in UK and Bob Krause that lived for 85 years with type 1 diabetes in USA. What is the problem with hyperglycemia in elderly people? There is coexisting illnesses, poor nutrition, genetics, medications, reduced insulin secretion, increased adipose tissue, and decreased physical activity. Diabetes is one of the most common chronic diseases in older adults. Of people of more than 65 years old, about 27% of them have diagnosed or undiagnosed diabetes. Having a 10 years reduction in life expectancy and mortality is nearly twice that of people with diabetes for people of the group of age of more than 65. They are at higher risk than those without diabetes for geriatric syndromes, including incontinence, falls, frailty, cognitive impairment, and depressive symptoms. And they, in general, have a higher prevalence of functional impairment and disability. The diabetes prevalence increased with age, and we can see for the age group of 60 years old in the United States, for example, about 20% of them have diabetes, compared with only 10% from the group of age 40 to 60 years old. And the life expectancy from birth, in general, it's higher for women than for men, for all age groups, since the birth, and especially for older population. And we can see that even in the UK, for example, females are living much longer than males. And there are a lot of conditions associated with diabetes mellitus in older adults, as it is premature death, functional disability, hypertension, coronary artery disease, cardiovascular disease, depression, cognitive impairment, and other outcomes such as blindness, renal failure, amputation, infection, coronary heart failure, hospitalization, and disability. There are some myths that exist that high prevalence of diabetes in older adults is inevitable. Hyperglycemia in older adults is usually a benign condition. Reduced life expectancy makes the consequences of uncontrolled diabetes irrelevant, and the majority of older adults with type 2 diabetes are obese and need to lose weight. So these are some of the most common myths that exist about diabetes mellitus in older adults. As for the diagnosis of diabetes, there is no differences between the diagnosis of diabetes in younger population or in older population. So the limit is for fasting plasma glucose, it's 126 milligram per deciliter or 7 millimole, and impaired glucose tolerance for values from 110 to 125. What are the risks of diabetes in older patients? Number one is the cardiovascular disease. Number two is nephropathy. So it is very important to evaluate the glomerular filtration rate based in the age group. Neuropathy, retinopathy, and there are some new directions such as dementia, marker of bad outcomes, hyperglycemia, which is a bad predictor in those admitted with stroke and other acute disease. Prevalence of dementia is increasing in the general population. So it is about 6 to 10% present in people with the age above 65 years old, but it arrives almost 50% in those with age about 85 years old, and about 70% in those over 95 years old. And by the year 2025, it is expected that 2 million centenarians will live only in United States, living in public health concern as the new chronic disease. So we need to clinically evaluate older adults with diabetes for atherosclerosis disease and presence of comorbidity disease. Take a thorough medication history to assess the functional status and to screen for common geriatric syndromes such as urinary incontinence, falls, pain, cognitive impairment, and depression. Assess needs for education and self-management support and whether to involve a caregiver. In general, older adults have higher rates of premature death, functional disability, and coexisting illnesses. They are at greater risk for polypharmacy, cognitive impairment, urinary incontinence, injurious falls, and persistent pain. And we need to screen for complications that need to be individualized and periodically revisited, because inside of that, they are at higher risk for depression. In general, we have two groups of older patients: functionally independent and functional dependent, that could be in the subcategory A, that are frail, and subcategory B, that are with dementia, and the category 3, which is the end of life care. For all these groups and for the all function, low or intermediate or high, we can see that people with diabetes have a much higher risk for premature death, cardiovascular disease death, or any other mortality in general. So especially where the function is very low, it is very high the risk for premature death. So which would be the goals of diabetes management? The goals should be individualized, clinical targets for each older adult with diabetes, involving the caregiver when appropriate. To manage the goals, it will include the control of hyperglycemia and its symptoms, to evaluate and treat associated risk for atherosclerosis and microvascular disease, evaluate and treat possible diabetes complications with the aim to avoid hypoglycemia, to support diabetes self-management and education, and maintain or improve general health status. We need to consider life expectancy for the older adults with diabetes and the time needed for clinical benefit from a specific intervention in treating older adults with diabetes. Clinical trials have demonstrated that greater than 8 years are needed before the benefits of glycemic control are reflected in reduced microvascular complications such as diabetic retinopathy or kidney disease. And only 2 or 3 years are required to see benefits from better control of blood pressure and lipid. So we need to focus more on the treatment of hypertension and lipids than to have a very good metabolic control. As it is very well known, the table and the position statement from the ADA and EASD, where we need to be more stringent with young people with diabetes and a high life expectancy compared to people of older age and low life expectancy. So in this case, we need to control lipid and blood pressure to motivate for the smoking cessation, to have an appropriate diet and food care, to increase the possibility for diabetes education and self-management when it is possible, to have an appropriate nutrition, to help weight loss if it indicated, and to increase as much as possible physical activity. Home monitoring of blood glucose has not been found to be cost-effective in older adults with diabetes. Older adults with diabetes should undergo age-appropriate prevention interventions such as influenza and pneumococcal vaccination, or as it is the case actually with COVID-19 vaccination. A very careful food examination is recommended due to lower extremity infection and amputations being more common among older adults with diabetes, and we need to screen for kidney disease by testing for the presence of albuminuria, due also to the polypharmacy that is present in older patients with people with diabetes. For that, we need to calculate glomerular filtration rate, because even a normal, let's say, creatinine level couldn't be such normal. We have in this table two cases, a woman of 45 years old and a woman of 75 years old. They have the same height, the same weight, the same level of creatinine, but their clearance or glomerular filtration rate is completely different. And in the second, it's a man of 45 years old and a 75 years old. They have all the other parameters, meters, and weight the same creatinine level, and the clearance is completely different. So just to measure the creatinine and the blood, it's not sufficient for people with diabetes in older population. And what is the general goal for older people with diabetes? If they are functionally independent, the general indicated hemoglobin target could be as near as possible as for the other people with diabetes in general. But for those that are functionally dependent, for frail, it needs to be above 8.5%, and for people with dementia, more than 8.5%. And for the end of life, it's just to avoid the symptomatic hyperglycemia. So we don't need to be very strict about the metabolic control in older people, especially when they are frail. So we need to consider glycated hemoglobin between 7 and 8.5 if they have a life limited expectancy, high level of functional dependency, extensive coronary disease at high risk of ischemic event, multiple comorbidities, history of recurrent severe hypoglycemia, and hypoglycemia unawareness. And we need to avoid as much as possible hypoglycemia. What is the treatment for older people with diabetes? We know that metformin is the first-line therapy, with sulfonylurea as the second choice, and as a second-line therapy could be used sulfonylurea and DPP-4 inhibitors, while the metformin could be added after that. But in older people with diabetes should be encouraged to be as active as their health and functional status allow, and the risk assessment should be undertaken before recommending an activity program, and time and type of activity should be considered in relation to the medicine regimen, especially glucose-lowering agent associated with an increased risk of hypoglycemia. So we need to choose wisely the treatment for people with diabetes, especially for the metabolic control of diabetes. And there is no evidence that using medication to achieve tight glycemic control in most older adults with type 2 diabetes is beneficial. Not always is lower is better, as we have learned from studies like ACCORD, ADVANCE, and they are here in the United States. So we need to be less stringent for people that are in high risk for hypoglycemia. They have a higher duration of disease and a short life expectancy like it is in people of older age with diabetes. And especially this is true for the perception of hypoglycemia, when we can see that for people of the age about 65 years old, they don't feel especially the hypoglycemia, and they recover very slowly compared to the people of the age of 40 to 64 years old. Which are the medications that have low or no risk of hypoglycemia that we can use in older adults? Alpha-glucosidase inhibitors, DPP-4 inhibitors, GLP-1 agonists. Meglitinides can be used because they have a lower risk than sulfonylureas in general. Metformin can be used, SGL2 transporter blockers, and TZD. But in some cases, we need to see also other secondary effects or contraindication, which like it is the renal function of people with diabetes. So we don't need to have any adjustment for epaglinide, but we need to have an adjustment for glimepiride and glizide. On the other hand, we can see that in general, the DPP-4 inhibitors can be used safely in people with type 2 diabetes of older age, especially the linaglutide. While for the GLP-1 agonist, we need to be a little bit more careful. And for the SGL2 inhibitors, there is no evidence, especially for older population, as it is the case that we are talking. For the cardiovascular risk factors, in general, for all people with diabetes of the age of above 60 years old, they could be considered at high risk. The cardiovascular and application of a risk equation is not necessary. So this category, the functionally independent old patient, should be treated as for younger people with diabetes, but for the category 2 that are functionally dependent, the emphasis should be on the identification and management of more easily modifiable risk factors such as hypertension and dyslipidemia. Treatment of hypertension is indicated in most older adults with diabetes, and lipid lowering and aspirin therapy may benefit those with life expectancy at least equal to the time frame of primary or secondary prevention trial. The best target blood pressure for all the diabetic patients is unclear. For healthier patients with few comorbidities, blood pressure of 220, 240 for systolic and 70 to 80 for diastolic could be ideal. But in some older adults may not be able to tolerate aggressive blood pressure. So in this case, we need to be more careful, especially for orthostatic hypotension that can lead to a fall and potential hip fracture resulting in functional limitation. Most use a patient-centered approach when deciding on treatment of blood pressure. Lower blood pressure gradually could help to avoid such problems in older adults with diabetes. Most antihypertensive drug classes have comparable effectiveness, and ACA inhibitors and angiotensin II blockers have cardiovascular and renal benefits for people with diabetes in general and for older population also. The risk of fall is very high in older people with diabetes, and all these patients should have an assessment of their fall risk during the initial visit, annual review, and if there is a recent history of fall. All for education and the fall prevention program to those with high risk of falls or recent history of fall, and provide education to all older people with diabetes about fall prevention. Assess vision regularly and provide correction as needed, and home safety should be regularly checked and modify it as needed. One important issue for older people with diabetes that in general are living alone or just a couple without children anymore, we need to assess for depression. We need to assess and monitor the depressive symptoms in older people with diabetes and be part of an integral start of care in annual basis. People with diabetes and caregivers should be taught to recognize early warning symptoms and signs of depression or change in mood. And the involvement of the family is essential to enhance socialization, communication, and support. And with that, it is related to fear of hypoglycemia and the lack of physical activity to improve the general mood for these people. Frailty is a widely used term associated with aging that denotes a multidimensional syndromes that gives rise to increased vulnerability. Polypharmacy is another issue for people with type 2 diabetes of older age. What is the definition? Whenever a drug is not indicated or a triangle working as a team, prescriber, patient, and other, nurse, physician, assistant, and caregiver. There is some studies showing that about 40% of older people with diabetes were overtreated, and from them, 20% were of the age above 70 years old. Hypoglycemia occurred in 20% of these patients, and almost 30% reported accident involving fall. And this is due also to the polypharmacy of people with diabetes. Another issue is diabetes in nursing home, where undernutrition is a problem in people with diabetes. Regular diets may be used in nursing home instead of diabetic diets or diabetic nutritional formulas. So, for the people with diabetes, we need to have a kind of checklist to assess the level of functional dependency, individualize glycemic targets based on the above glycated hemoglobin, avoid hypoglycemia in cognitive impairment, select anti-hyperglycemic therapy carefully, caution especially supernuria or TZD, basal insulins instead of NPH or mixed insulin, and give regular diets instead of diabetic diets or nutritional formulas in nursing home. So, as a recommendation for healthy elderly people with diabetes should be treated to achieve the same glycemic blood pressure and lipid target as younger people with diabetes. But in the frail elderly, while avoiding symptomatic hypoglycemia, glycemic target should be on a glycated hemoglobin of 8 or below 8.5 and the avoidance of hypoglycemia. In summary, patients have different requirements depending on diabetes status, but not only on that, because many choices exist to individualize treatment, to reinforce lifestyle, to treat blood sugar, lipids, and blood pressure. Not all the patients are the same. Age is more than a number. Its physiological age may be very important. Recognition of difference between life expectancy and given age and average age is very important to decide for our goals. And recognition that frail patient is different from the robust patient regardless of age. What is very important is education strategy where listen the needs of the patient is very important, having a positive attitude to provide meaningful, practical, individualized information, to prioritizing needs with the patient and assist with the problem solving and goal setting with the kind of empowerment model in patient center. So only in this way, people with diabetes will have a longer life expectancy and have a healthy life even in an old age. Thank you for inviting me